Hello all, as promised, this is going to be an Emree recall video of Jan 4 2026 exam which I had given this year. As I had mentioned, it was a little bit trickier exam. There were repeated questions with just one or two words here and there. But overall, it was a little bit trickier. Mainly, they asked about the diagnosis, what is the next line of management or investigation. And there were image-based questions as well, but they were on the easier side. So let's see. I have not, it's not like a word-to-word same question. These are more like scenarios which I have tried to frame into questions, most of them. Other questions I've just put what was the topic about. So let's get started. So the first question is, a 22-year-old man presents to emergency with 12 hours of abdominal pain. The pain initially started around periumbilical region, later migrated to lower quadrant. He has nausea, loss of appetite, and low-grade fever. So these are so many clues as to the diagnosis. So this is abdominal pain, acute abdominal pain, started around the periumbilical, later migrated to lower quadrant, right lower quadrant, and also associated nausea, loss of appetite, low-grade fever. Okay. These are the things. And on examination, there is raised temperature, pulse is raised again due to fever, tenderness and guarding in the right iliac fossa, and rebound tenderness. So mostly in acute abdomen, the diagnosis comes from the site of pain and the presentation. So if it's epigastric pain radiating to the back, associated with vomiting, it can be pancreatitis. If it's a right upper quadrant pain, maybe with jaundice, that is a Charcot's triad, it can be a cholangitis. Or again, the Murphy's tenderness can be due to cholecystitis, that is a gallbladder inflammation. Then, if it is lower down, that is right lower quadrant, it can be acute appendicitis, right? And the age, everything will come into play. So acute cholecystitis is mentioned. It's the pain over the Murphy's point, that is due with deep in a sudden uh, pain when you are palpating over the right upper quadrant. Pancreatitis, it's epigastric pain radiating to the back associated with vomiting. Appendicitis fits to the diagnosis, right? Meckel's diverticulitis, again, you know the rule of two, we'll discuss that. Okay, so this fits into acute appendicitis. So that is the answer, acute appendicitis. Not pancreatitis, appendicitis. When I read the question, you try to frame the answer in your mind and then uh, go into the discussion part. Okay. So here the diagnosis was acute appendicitis. It's usually clinical diagnosis, and the investigation is mainly to rule out any other causes. Like we can sometimes find appendicitis in USG, but if USG comes out clean, that doesn't exclude appendicitis. So it's mainly a clinical diagnosis. When we look at the Alvarado score in order to make a diagnosis, in that right lower quadrant tenderness and leukocytosis, that is more than 10,000 WBC, comes out to be more than 2 of a 2 score. All others like elevated temperature, rebound tenderness, anorexia, nausea, vomiting, migration of pain to the right lower quadrant, and left shift, that is leukocytosis, all comes out as 1 points. In this patient, they had all these things, that is right lower quadrant tenderness, elevated temperature, rebound tenderness, anorexia, nausea, vomiting, and migration of pain to the right lower quadrant. So this is more likely to be acute appendicitis. We'll discuss other options as well. So what were the other options? There were cholecystitis. When you hear cholecystitis, you may sometimes confuse it with cholangitis as well. Cholecystitis means it is the inflammation of the gallbladder itself, that is obstruction of gallbladder outflow resulting in inflammation. Mainly there is right upper quadrant pain along with nausea, vomiting, and it's usually postprandial abdominal pain, especially with fatty meals. That is one history that you can get. And there is the Murphy's point, Murphy's sign. That is when you're with this inspiration and you're palpating over the right upper quadrant, there is a wincing pain. That is cholecystitis. What about cholangitis or ascending cholangitis? It usually presents with a triad, right? Charcot's triad. That is right upper quadrant pain along with jaundice and fever. If it is severe, there is Raynaud's pentad, that is Charcot's triad, along with altered mental status and shock, that is Raynaud's pentad. Okay, in cholecystitis and cholangitis, you need antibiotics. In cholecystitis, after that patient becomes stable, maybe during the same admission, once the infection settles, you can go for a elective cholecystectomy. Not during the acute episode, but during the same admission, or as an interval cholecystectomy also. In cholangitis, if it is due to any stone, you can diagnose it with an MRCP and then do an ERCP, endoscopic retrograde cholangiopancreatography, and then do maybe a standing and endoscopic ultrasound guided drainage, percutaneous drainage, or surgical drainage. That is with cholecystitis, and we have also included cholangitis so that it doesn't confuse you. How about pancreatitis? Pancreatitis mainly it's a epigastric pain which is radiating to the back, and we have a criteria for the severity of acute pancreatitis. We calculated at admission and at 48 hours after admission. At admission, the main criteria we look into is the age, the WBC count more than 16,000, blood glucose more than 11, AST more than 250, LDH more than 350. And at 48 hours, it is the serum calcium, low serum calcium or hypocalcemia, hematocrit fall more than 10%, oxygen, that is hypoxemia, BUN increased by 1.8, and base deficit and sequestration of fluids. Sometimes in the previous question, what I have seen is one criteria which helps diagnose severity of acute pancreatitis in the first 48 hours, and they in the options they mentioned the serum calcium level or hypocalcemia. So that is one criteria. Okay, just make sure you have this in mind, just you know about it. Sometimes they may ask to choose a criteria which can help diagnose the severity of acute pancreatitis or the mortality rate and all. Then we have Meckel's diverticulum was also in the option. So Meckel's diverticulum, there is a rule of 2. That means it is usually seen in 2% of population. It's 2 times more common in male, and it is 2 feet proximal to the ileocecal valve. It's 2 inches in length. And usually there are 2 types of common ectopic tissue found in the Meckel's diverticulum. One is the gastric tissue and other is the pancreatic tissue. Okay, that is it. Next question, a 55-year-old woman presents to emergency with fever, right upper quadrant abdominal pain and jaundice for the past 2 days. So there is fever, right upper quadrant pain and jaundice. Something strikes in you. The triad, right? Charcot's triad. Fever, right upper quadrant pain and jaundice. And she also complains of nausea and vomiting. Temperature is 39, pulse is 112, blood pressure is 90/60. She appears confused and toxic. So there is shock along with confusion. Now it becomes Raynaud's pentad, right? Ultrasound shows dilated common bile duct with a stone. So it can be due to the presence of stone. There is a obstruction and there is inflammation. What is the most likely diagnosis? So we have seen the triad and the pentad. Raynaud's pentad. What is it suggesting? It is suggesting acute cholangitis, not cholecystitis. Okay, don't get confused. Cholecystitis pain is usually the right upper quadrant pain along with Murphy's sign. There can be fever, but this is not cholecystitis. This is cholangitis. This is the inflammation of the duct, and cholecystitis is inflammation of the gallbladder. Here the obstruction is in the duct. So it is acute cholangitis or ascending cholangitis. We have seen already the difference between cholecystitis and cholangitis. And why not viral hepatitis? Viral hepatitis can be again with fever, there can be nausea, vomiting. These are all associated symptoms. But this Again, there can be jaundice, okay, but this presentation along with the dilated common bile duct to the stone, that is the ultrasound finding, more suggestive of the cholangitis picture than a viral hepatitis. And acute pancreatitis, again we have discussed it. It is usually the epigastric pain which is radiating to the back, and along with vomiting, there is Ranson criteria which you can assess the severity at the time of admission as well as 48 hours after admission. So that is acute cholangitis or ascending cholangitis, mainly fever, jaundice, abdominal pain, okay, as a result of stasis and infection of the biliary tract, not the gallbladder itself, but the biliary tract. Okay, there can be a common bile duct obstruction and there can be inflammation. And the triad is fever, abdominal pain, and jaundice, which is called Charcot's triad. Along with that, if there is confusion and hypertension due to the severe infection, it's called Raynaud's pentad. Mainly you manage with broad spectrum antibiotics along with biliary drainage. If there is obstruction due to stones, you may have to go for an ERCP. Before doing an ERCP, you usually do an MRCP to actually localize the site and all. Then you can go for an invasive technique like ERCP. Next question, a 9-month-old infant is brought to emergency with sudden onset intermittent episodes of crying during which the child draws up his knees to the chest. Between episodes, the child appears relatively well. The mother reports vomiting and passage of blood-stained mucus mixed stool. That's a 9-month-old child, right? So the age of presentation is also very important. On examination, child is irritable. A sausage-shaped mass is palpable in the right upper quadrant. Abdomen is mildly distended. What is the most likely diagnosis? In a case of acute abdominal obstruction, intestinal obstruction, in a child, in an infant who is within the 5 years of age, usually 6 months to 5 years, we usually think about intussusception even though it does not explicitly mention sausage-shaped mass, because that is not like a very pathognomonic finding. So we may not expect to find it, but if it is given in the question, well and good, and there can be blood-stained mixed stool as well. And what is the most likely diagnosis? So this is a case of intussusception, right? Why not intestinal volvulus, mainly in the adult population? Why not Hirschsprung? Hirschsprung is usually presenting even in earlier part of the neonatal period itself, that is delayed meconium passage. If at all they did pass meconium even after 48 hours, again they'll have obstruction along with vomiting and all. Okay, that is due to absence of ganglion cells in the distal part of the colon or rectum. Meckel's diverticulum, again diverticulum can get inflamed, there can be diverticulitis, fever, and there can be blood in stool and all. But usually Meckel's diverticulum, again, is not how this sausage-shaped mass and all is not very characteristic of the Meckel's diverticulum. So this is a case of intussusception. What is intussusception? Intussusception is where one loop of the bowel is telescoping into another part of the bowel. Usually the small intestine is telescoping into the large intestine. Okay, and there is two parts of the intussusception, one which is getting into and the other which is receiving. That receiving is called the intussuscepient, recipient, and one which is one part of the bowel which is looping into that other part is called the intussusceptum. So intussusceptum and intussuscipients. And in USG you can get a target sign. Okay, target sign. That is an outer bowel loop with an inner bowel loop. Because we will there'll be a halo between the inner bowel and outer bowel, because there will be some hair space between that, right? And the mesentery sometimes. That is why we get this target sign. And then barium, gas barium or other barium enema, we get a close sign. That can be diagnostic as well as therapeutic, because once you fill in with pressure, it can get out of the other loop. Okay, that is Gasperi minima. Next question is a 3-day-old full-term male neonate is brought with abdominal distension, poor feeding. Okay, there is distension and poor feeding, and it's just 3-day-old full-term baby. Passed meconium 48 hours after birth. That means that it was a delayed passing of meconium, because actually meconium should be passed within 48 hours after birth and urine should be passed within 24 hours after birth. Since then, he has not passed stools and has developed bilious vomiting. On examination, abdomen is distended. Rectal examination results in explosive passage of stool and gas. What is the most likely diagnosis? And the image was also given. That means there is abdominal distension, there is abdominal obstruction, intestinal obstruction. So what is this? It is a 3-day-old baby. So what are the options? Meconium, ileus, neonatal sepsis. Neonatal sepsis, there will be septic features. The child would be too floppy and there will be fever, right? Hirschsprung disease, small bowel atresia. Small bowel atresia means like a duodenal atresia or something. Duodenal atresia, you get a double bubble sign, right? That is not what we see in this erect X-ray. So that is unlikely. Here, the most likely diagnosis is what? Hirschsprung disease. Hirschsprung disease. What is Hirschsprung disease? It is absence of ganglion cells in the distal part of the rectum or the colon. Okay, so how do you diagnose it? The gold standard becomes the rectal biopsy, wherein you can demonstrate the absence of ganglion cells, but rectal manometry can show the absence of rectal anal inhibitory reflex. Okay, and this is the ganglions innervating the colon, but here you can see there are no ganglion and no colon movement. So what you do is the Duhamel pull-through procedure. You have to resect the ganglionic segment and do a anastomosis. Or sometimes you will have to bring out the colon as a storm outside also, depending on the situation. Next question is a 28-year-old woman, 16 weeks pregnant, is found to have an adnexal mass, that is an ovarian mass, adnexal mass during routine antenatal ultrasound. The mass measures 9 cm, is solid with irregular border. It shows internal septation, has increased vascularity on Doppler. There is no ascites. She is asymptomatic and the pregnancy is otherwise normal. What is the next best management? So this is about an adnexal mass detected during pregnancy, and she is 16 weeks pregnant. So how do you work up and treat an ovarian mass or a cyst in the ovary which is detected during pregnancy? So there can be two scenarios. Either the cyst is detected during early pregnancy. In that case, it can be a corpus luteal cyst which can regress during late part of the pregnancy. Unless it is a very big cyst which has a risk of torsion, you may have to intervene. Otherwise, the cyst is big enough to cause trouble, or it's completely asymptomatic and it's a small cyst, you don't have to worry about it. But here in this patient, she's already in her second trimester and it's big enough, that is 9 cm, and there are some suspicious features of malignancy, right? Like there is solid with irregular border and internal septation and has increased vascularity on Doppler. All these are like red flag signs in an ovarian mass. And when the patient is already in her second trimester, the best management becomes to resect that ovarian mass as soon as possible in the second trimester itself, because if it was detected in the first trimester, the risk of miscarriage is higher. If it's in the late part of pregnancy, again it can lead to preterm delivery. The safest window is in the second trimester. So what do? You have to surgically remove in the second trimester. Chemotherapy is not indicated because we don't know the diagnosis yet. Termination of pregnancy followed by surgery. There's no indication for termination of pregnancy because her pregnancy otherwise is very well normal. Conservative management, repeat ultrasound after delivery? No. This is something you cannot conservatively manage because the size is too big. There are suspicious features. So if you are keeping it until after delivery, the risk of malignant transformation can be high and the complication can also follow. So it's better you deal with it now during the second trimester. If it's laparoscopically removed, it will be better. So surgical removal in the second trimester becomes the justifiable choice because there are suspicious features in this case like solid component, irregular margin, septations, increased Doppler flow, and size more than 8 centimeter or more than 5 centimeter itself. We are a little bit concerned. And the optimal timing is second trimester because in first trimester there is increased miscarriage risk. If you are delaying till postpartum, there is malignant transformation risk. So usually most ovarian masses are benign only. So if it's a simple cyst less than 5 to 6 centimeter, you can observe, especially if it's detected in the first trimester, it can be a corpus luteal cyst. If it's a complex or suspicious mass with the mentioned features like solid component, irregular margin, the septations, and all those features, you may have to operate, mainly in the second trimester. So this is how you deal with the cyst in pregnancy. If it's asymptomatic, uh, uh, but there are suspicious ultrasound findings, and you suspect for malignancy, you have to surgically treat. If it's symptomatic, again, like there is structure or torsion, again you have to surgically treat. Okay, uncertain ultrasound findings or benign ultrasound findings with size less than 5 centimeter requires just monitoring surveillance. You have to repeat ultrasound sometimes later to see if it's regressing. If it's uncertain findings, monitor until 16 weeks of gestation, and if it's found in the first trimester, and if it's persistent, again monitor, and if there are any malignant transformation changes or any suspicious findings, you may have to operate. If it's non-persistent, you can leave it. Next question, a 19-year-old male with multiple inflammatory papules and pustules over the face and upper back for the past 8 months. He has tried over-the-counter benzoyl peroxide with minimal improvement. There are no nodules or cysts, but there are early post-inflammatory hyperpigmentation mark. What is the most appropriate next step in management? So this is a case of acne. So acne management, it's a stepwise management. If it's like simple pustules or papules, you can try giving them a topical benzoyl peroxide along with the topical retinoid. But if it is persistent, if it's resistant to benzoyl peroxide, if it's not improving, you may have to add oral antibiotics. Now, if there are so many nodular cystic changes, then it's a very severe acne. That means you would need oral antibiotics along with oral vitamin A. Okay, oral isotretinoin. But here in this case, there are no nodules and there are inflammatory papules and pustules, and the patient has just tried topical benzoyl peroxide. So there is scope of trying oral antibiotics along with topical retinoid. Okay. So topical benzoyl peroxide alone would not be effective in this patient because he's already tried that. Topical retinoid alone, no, retinoid is usually given along with oral antibiotics because they have inflammatory papules and pustules. Oral acetretinoin becomes the last resort if it's severe nodulocystic changes. Okay, so topical retinoid plus oral antibiotics. This is the stepwise management in acne. Like mild, moderate, severe. Mild means there are only comedones with or without few pustules and papules. It's not very severe. You can try topical retinoid and benzoyl peroxide. If it's moderate, like widespread papules and pustules, you have to add oral antibiotics along with the topical retinoid. You can continue using benzoyl peroxide also. If it's severe, nodulocystic or resistant to antibiotics, you can add oral isotretinoin. And the antibiotics have to be given to for a longer period, like 4 to 6 weeks, in order to get some benefit. Okay, so that is acne management. Next is a 35-year-old woman presents with a slow growing painless swelling on the right side of face for the past 2 years. Swelling is firm, non-tender, measures about 4 centimeter, located in the front of ear, becomes more prominent when she clenches her teeth. Okay, the overlying skin is normal. Mass is not freely mobile. No cervical lymphadenopathy. What is the most likely diagnosis? So it's a swelling of the face, slow growing, painless, not freely mobile, and it's getting prominent when you're clenching your teeth. So it's some swelling over the parotid, most likely. So what is the most likely swelling on the parotid? Among the options, lipoma, dermoid cysts, pleomorphic adenoma, sebaceous cyst. You have to know the characteristic and the location of usual swelling, skin swelling. Lipoma, usually over the nape of the back or the sebaceous, again on the fatty areas you can have, or any place you can have a lipoma, but it's usually very freely mobile, slippery, and it's soft, right? So this is unlikely to be a lipoma, especially over this location when it is getting prominent with clenching of your teeth. It's more likely to be a parotid gland swelling rather than a lipoma. How about dermoid cysts? Dermoid cysts are usually on the midline. In the midline, you can have dermoid cyst. Pleomorphic adenoma, that is the most common tumor of the pituitary of the parotid gland. So that is pleomorphic adenoma. It can be seen in the parotid gland as well as the submandibular gland. How about sebaceous cyst? Sebaceous cyst usually has a punctum. Again, usually found over the sebaceous areas, or over the chest area, okay, or anywhere else as well. So here it is pleomorphic adenoma. It's the most common benign salivary gland tumor, arises from the parotid gland or sometimes from the submandibular. It's slow growing, painless, firm mass, located pre-auricular or over the angle of jaw, and the skin is normal. And there is one sign called the curtain sign. Okay, and it lifts the ear lobule. Okay, and it's not freely mobile because the parotid sheath will be attached to the zygomatic arch, so that is why you cannot lift it above that. Okay, its mobility will be restricted, and the sign is called curtain sign. Okay, and it can lift the earlobe. It can get prominent with clenching of teeth. It's usually slow growing, painless, and firm mass. Lipoma, if it was a lipoma, it would have been soft, freely mobile. It's a doughy consistency with a slip sign positive. Dermoid cyst usually midline. It's again soft and cystic. Sebaceous cyst, it would have had a punctum. Next question, a 42-year-old man presents with slow growing swelling over the posterior aspect of his right shoulder, noticed over the past 3 years. Swelling is painless, soft and freely mobile. Overlying skin appears normal with no redness or discharge. Again, the location of the swelling is very important. Now the swelling is over the right shoulder and it's painless, soft, freely mobile. Look for the characteristics of the swelling. That will give you a clue of what is the diagnosis. Just like we have discussed before, dermoid cyst would have been midline. Lipoma is a soft, freely mobile, slip sign positive, right? So it can be a lipoma. Sebaceous cyst, it usually has a punctum. It can discharge pus and all. It's usually painful. Neurofibroma, again, it can have multiple neurofibromas, okay? Not just a single big swelling. So this is likely to be a lipoma. So this is a lipoma. Lipoma usually can be present over the shoulder or over the nape of neck. Okay. Next, a 68-year-old man presents with lower urinary tract symptoms, including poor stream, hesitancy, nocturia for the past 6 months. Okay, poor stream. That is most likely to be in a 68-year-old, that is elderly man with poor stream, urgency, hesitancy, and dribbling of urine, all can be associated with the prostate swelling. It can be a benign prostatic hyperplasia or a prostatic cancer. On digital rectal examination, the prostate is hard, irregular, and nodular. So there are some changes in this prostate. It doesn't seem to be uniformly enlarged like in a BPH, benign prostatic hyperplasia. It's hard, irregular, and nodular, but there is no fever or dysuria. So there is no active infection in the prostate gland. The PSA is elevated. PSA usually can be elevated in prostatitis also, but here the patient has no fever, no dysuria, and the DRE finding, digital rectal examination finding, is also suggestive of some changes in the prostate, which is irregular and nodular mass. Urine routine is normal. What is the next best step in management? So this seems like a red flag signs in a prostate mass. So you have to rule out prostate cancer. So how do you rule it out? Options are start alpha blockers, review after 6 weeks. No, that will resolve the symptoms of the patient, but that will not conclude whether it's a benign or malignant swelling. So you need a biopsy. How do you take a biopsy? Is it transurethral or transrectal? That is the question, because the options are transurethral resection of prostate. That is not yet to be done because you have to make a diagnosis first. Even if it's a prostate cancer, you have to work up the patient first. You have to take them for a PET scan to see if there is any distant metastasis, because prostate is very well known for bony metastasis. So transrectal ultrasound or transurethral biopsy. Transrectal ultrasound guided biopsy under antibiotic cover. That's what usually done. Transurethral resection can be done, but biopsy is taken usually transrectally, and antibiotic cover is given because there can be a rectal flora. It can get dislodged and can lead to infection. That is why we are doing it under antibiotic cover. So it's transrectal ultrasound guided prostate biopsy under antibiotic cover. Hard nodular prostate with raised PSA. So there is suspected carcinoma prostate. So the confirmation requires histopathology, and it's always done under antibiotic cover to prevent sepsis because of the rectal flora. Next is a 60-year-old man presents with fever, right upper quadrant pain, and jaundice. Investigation revealed raised bilirubin alkaline phosphatase. Ultrasound shows dilated CBD, that is common bile duct with obstructing stone. So there is stone, fever, right upper quadrant pain, jaundice. Okay, that seems like a cholangitis. Raised bilirubin and alkaline phosphatase. Raised bilirubin can be due to the obstruction, that is, the conjugated bilirubin can be raised, and alkaline phosphatase can be raised due to any cause, right? Even an obstruction in the biliary tract can cause a raised ALP. What is the underlying mechanism responsible for this condition? So we understood that this is a cholangitis. So what is the underlying mechanism? Is it autoimmune destruction of the intrahepatic bile duct? No, autoimmune destruction means it's an autoimmune condition, right? Here it is due to obstructing stone and then inflammation. Ascending bacterial infection of the biliary tract due to obstruction. That seems like an option, right? What are the other? Direct hepatocellular injury from bile acids. No. Viral infection of hepatocytes. That is viral hepatitis. No. Doesn't seem like viral hepatitis. It seems like ascending cholangitis. So that is ascending bacterial infection of the biliary tract due to the obstruction from the stone. Okay, that is the cause. So ascending cholangitis, we had two questions. One was to diagnose ascending cholangitis, other was what is the mechanism behind it. Okay, so there were multiple questions based on the same topic, somewhere like a little bit twisted here and there. Okay, so be careful, read the question carefully and see what they are asking you for. Next question, a 64-year-old man presents with progressive painless jaundice for 3 weeks. He also reports dark urine, pale stools and pruritus and unintentional weight loss. There is no abdominal pain. On examination, icterus is present, palpable non-tender gallbladder and no fever. Okay, so there is 3 weeks duration, progressive painless jaundice and pale stool, pruritus, dark urine. What does that seem like? It seems like obstructive jaundice. Okay, because the stools will be pale and there can be pruritus due to the bile acids getting into the bloodstream, and unintentional weight loss can be some red flag sign of a malignancy. There is no abdominal pain. There is icterus present and palpable non-tender gallbladder. What is the dictum of gallbladder stone? If it was a stone, if it would have made the gallbladder small, like it would have been shrunk. Okay, so it is unlikely to be stone. What is the most likely diagnosis? Cholangiocarcinoma, that means carcinoma of the duct. Cholangio is related to the duct, cholangitis, cholangiocarcinoma, right? Carcinoma head of pancreas, chronic pancreatitis, carcinoma gallbladder. Chronic pancreatitis can be a chronic event with acute exacerbations, maybe with acute pancreatitis. But this doesn't seem like the history. Carcinoma gallbladder means gallbladder cancer. But here it's with obstructive jaundice, with a palpable non-tender gallbladder, it is most likely to be a carcinoma head of pancreas. Okay, because there is some law called Cavour's law. That means a patient with jaundice due to a gallstone in the common bile duct is likely to have a fibrotic shrunken gallbladder that is impalpable. So with jaundice, if you get a palpable gallbladder, it's very unlikely to be due to stones. That's what it says. And that means in this case, we have jaundice along with the palpable gallbladder. So it's unlikely to be due to stones and more likely to be due to other cases like malignancy. A patient with jaundice due to any other another cause may have a palpable gallbladder. So if it is gallbladder in gallstone in CBD causing obstructive jaundice, the gallbladder is usually fibrotic, shrunken, and impalpable. But if the jaundice is not caused by gallstone, it's usually palpable. And for carcinoma head of pancreas, we are resecting the tumor, okay, and the adjacent portions will resect a part of stomach, duodenum. All this will be resected and we make anastomosis. So the three anastomoses, one is choledochojejunostomy, that is for the bile flow from the liver, okay, directly from the liver, that is choledochojejunostomy. There is gastrojejunostomy because the gastric part is also, a stomach is also distally cut. That will be reunited with the jejunum. There is a pancreaticojejunostomy for the flow of pancreatic juice, right? So there are three anastomoses here. That is called the Whipple procedure. Question: of 58-year-old woman presents with chronic ulcer over the medial malleolus of her left lower leg. So when it's a lower leg ulcer or any ulcer, look for the location first. Medial malleolus, usually venous ulcer. On the sole, usually diabetic ulcer, neuropathic ulcer, right? For the past 6 months, she has a history of long-standing varicose vein. So she has a history of varicose vein, so more likely to be venous ulcer. And prolonged standing at work, ulcer is associated with aching pain, worsens on stand, improves on leg elevation. Why improves on leg elevation? Because the venous drainage is better when leg is elevated. Surrounding skin shows hyperpigmentation and lipodermatosclerosis. These are changes associated with varicose vein itself. Peripheral pulses are palpable, so it's unlikely to be diabetic in nature because there can be diabetic neuropathy, arteriopathy, and it can lead to PVD, peripheral vascular disease, and the pulses can be feeble. So here, what is the most likely diagnosis? It is venous ulcer, not arterial ulcer, not neuropathic or diabetic ulcer, not a pressure ulcer. Pressure ulcer is usually again on the sole of the feet. It's venous ulcer. That was one question, but there were other questions, similar presentation, and they asked what is the etiology, and the option had venous hypertension. So venous ulcer, the etiology is venous hypertension. There is raised pressure in the veins, which is makes it unable to drain back the blood into the heart. So it pulls and it has varicosities, and there is venous ulcers as well, especially over the medial malleolus. You have to do a Doppler of both the arterial and venous system of both the lower limbs to assess for the arterial flow as well before you give them compression stockings. Because for venous ulcer and varicose pain, the main treatment is compression stocking so that the drainage will be much improved. This is a CAP classification of the venous disorder. Sometimes they ask what is the category of this uh, venous of this varicose vein. So C1 means that is based on the clinical manifestation. C1 means telangiectasias or reticular vein. These are like small veins, okay, very small in diameter. C2 means very obvious and engorged veins, which are like varicose vein. C3 means edema. C4 means C4A is pigmentation. C4B is lipodermatosclerosis. That is something that we have seen in this patient, right? And corona phlegmatica, that is C4C, that is the discoloration again. And C5 is healed ulcer, C6 is active venous ulcer. Based on etiology also, we can classify them into congenital, primary and secondary, EC, EP and ES. And based on anatomy, it can be either the superficial system alone are involved, or the deep venous system, or the perforators, or multiple systems can be involved together as well. Pathophysiology can be due to obstruction or due to reflex from the perforators and all. How about other ulcers? Arterial ulcer, it's usually punched out, painful with absent pulses. Diabetic ulcer, usually on the plantar surface. Again, it's painless. Pressure ulcer, usually on the bony prominences like the heel pad. If the patient is prolonged bedridden, it can be on the pressure areas like the gluteal area, right? That is how it comes. Next question, a 45-year-old man presents with progressive dysphagia to both solids and liquids for the past 1 year associated with regurgitation of undigested food and weight loss. There is no history of odynophagia. Barium swallow images shown. So the barium swallow is showing a bird beak appearance, right? This is called a bird beak appearance, right? And there is dilation of the proximal segment of the esophagus. This is what we see in this barium swallow. What is the most likely diagnosis? Is it esophageal carcinoma? No. Carcinoma usually it's like a rat tailing and there is a stricture. Is it peptic stricture? No. Diffuse esophageal spasm, there will be corkscrew appearance. Achalasia cardia, that is the diagnosis. Achalasia cardia. Initially, there will be the dysphagia will be to liquids, then it will be to solids as well, and it is due to the failure of relaxation of the lower esophageal sphincter, right? So it is achalasia cardia. And you can use a manometry to show the failure of lower esophageal sphincter relaxation. And there is bird beak appearance in barium swallow. And the treatment of choice is Heller's myotomy. It's a surgical procedure. We can see two other things. What is this? And what is this? This is corkscrew appearance. So this is diffuse esophageal spasm, DES. And this is carcinoma esophagus. Okay, carcinoma esophagus. It can be a squamous carcinoma. Like in case of achalasia also it can predispose to squamous carcinoma, or if it was having already a varied esophagus, it can be adenocarcinoma. Next question, a 27-year-old presents with high-grade fever, chills, right-sided flank pain and burning micturition for 2 days. She has also had nausea and vomiting. So right-sided flank pain with fever, chills and burning micturition. What is it likely to be? It's UTI, complicated or uncomplicated? Complicated UTI because there is right-sided flank pain. There is raised temperature, pulse is elevated, costovertebral angle tenderness. That means there is some pyelonephritic features, right? You see hemodynamically stable, not pregnant. What is the most appropriate initial treatment? So if it's a complicated UTI, you have to give IV antibiotics like IV ceftriaxone. No antibiotics until culture report, that doesn't make sense because the patient is very ill. Oral nitrofurantoin, no, oral antibiotics cannot be given in this case because it's a complicated case. Again, oral trimethoprim sulfamethoxazole, that is called trimethoprim for 3 days, is not justifiable. So it's IV antibiotics for complicated UTI. A 19-year-old college student is diagnosed with acute meningococcal meningitis. His roommate, who is asymptomatic, shared the same hostel room for the past month. What is the most appropriate chemoprophylaxis for the roommate? Options are: no prophylaxis required, oral azithromycin single dose, oral rifampicin 2 dose, oral ciplox single dose. So in an adult or adolescent patient with close contact to meningococcal meningitis case, you need prophylaxis. The question is which one. You can give rifampicin also, you can give ciplox also. And ciplox is a single dose. So that becomes more reliable choice because of the compliance and all. Okay. So it is oral ciplox single dose. Next is 7-year-old boy with fever, headache, neck stiffness and vomiting. Fever, headache, neck stiffness, vomiting for past 24 hours. Positive Kernig and Brudzinski sign. So uh, more of a diagnosis of meningitis. There is no rash. That means meningococcal is out of picture. Lumbar puncture, not necessarily meningococcal will have rash, but mostly rash is associated with meningococcal meningitis. Lumbar puncture CSF findings, appearance is turbid. WBC is 1200, predominantly neutrophils. Neutrophils are mainly in bacterial meningitis, right? Glucose is 30, blood glucose is 100. That means glucose is low. Okay, less than 2/3 of the serum glucose, and protein is 220. That means it is elevated. So what is the most likely diagnosis? Predominantly neutrophils with low glucose, high protein. That is bacterial meningitis. Viral meningitis usually lymphocytes, fungal lymphocytes, tubercular lymphocytes mainly, right? We'll see the difference. So the pressure, bacterial meningitis, it can be elevated. In others, it is not a very diagnostic feature. Appearance can be turbinate, bacterial, fibrin, webs, and fungal once you keep it for long time. Protein is elevated in bacterial. In viral, it's not much elevated. Glucose is low in bacterial. In fungal, it's like somewhere in between. Gram stain can be positive in bacterial. CSF glucose to serum ratio is less than 0.4 in bacterial and fungal as well, but viral it is not reduced. WBC will be more than 500 in bacterial, and that is mainly neutrophils, and in viral it can be less than 1000, fungal can be 100 to 500. Mainly it can be lymphocytes. That is the difference. 28-year-old woman presents with dysuria and increased urinary frequency for 2 days, 2 episodes of uncomplicated UTI for the last 6 months, both of which responded well to oral antibiotics. She's febrile, hemodynamically stable, no flank pain, urine shows pyuria, urine culture has been sent and is pending. So this is a clear case of uncomplicated UTI. She had recurrent UTI, but they all responded well to oral antibiotics. So now what is the management? Do you wait for urine culture report before starting treatment, or you start cotrimoxazole or nitrofurantoin or IV antibiotics? IV antibiotics are not indicated because this is not a case of complicated UTI. So do you start cotrimoxazole or nitrofurantoin? Which becomes a choice? It is usually nitrofurantoin. So you can start nitrofurantoin because it's a uncomplicated UTI which has previously also responded to oral antibiotics, but you have to maybe do some more workup to see the underlying cause, like if there is any reflex, especially in younger children and all. If they are coming with recurrent UTI, in females it can be a VUR, a psychoureteric reflex, right? Or a posterior urethral valve. But uh, uh, but in adolescent, if it's elderly also, you can look for diabetes, any underlying cause which is predisposing them for the recurrent UTI. Okay, but the treatment can be orally itself because they have responded well previously. But there was another question which was a similar presentation. 32-year-old with dysuria, urinary frequency, lower abdominal pain for 3 days. Had multiple recurrent UTI over the past year, but there was poor response to oral antibiotics during her last episode. She is febrile, urine routine shows significant pyuria, culture sent pending. What is the most appropriate next step in management? Now, do you give cartramoxol or IV antibiotics, or urine culture, or nitrofurantoin? Here you can start IV antibiotics because they had a poor response to treatment previously and also a little bit febrile and having all the symptoms. So this is how the different questions were a little bit trickier to solve. So read the question carefully before you jump into the answers. We'll discuss the next questions in the upcoming video. So stay tuned. All the best for all of you who are preparing for this cycle. Thank you so much.